Chronic obstructive pulmonary disease or COPD affects millions of people worldwide and remains one of the leading causes of illness and death. In this video, we will simplify the GOLD 2026 guidelines and cover diagnosis, ABE classification, medications, inhaler therapy, exacerbation management, and important new updates. By the end of this video, you will understand how COPD is diagnosed and treated according to the latest recommendations. COPD is a chronic progressive disease characterized by persistent airflow limitation. It mainly includes chronic bronchitis and emphysema. Patients commonly experience shortness of breath, chronic cough, sputum production, and wheezing. Smoking is the most common risk factor, although exposure to the biomass fuel, air pollution, occupational dust can also contribute. The diagnosis of COPD requires spirometry demonstrating a post-bronchodilator FEV1 to FVC ratio of less than 0.7. Common symptoms include progressive shortness of breath, especially during physical activity, chronic cough with or without sputum production, recurrent respiratory infections, wheezing, and fatigue. A detailed history should also explore smoking habits, exposure to pollutants, occupational risks, and family history. These clues can raise the suspicion for COPD and prompt spirometry testing. The GOLD 2026 report classifies patients into Group A, B, and E based on the symptoms and exacerbation history. Group A patients have mild symptoms and infrequent exacerbations. Group B patients experience significant symptoms but have a low risk of exacerbations. And Group E includes patients who have frequent or severe exacerbations and therefore require more intensive treatment. This classification helps clinicians individualize therapy and improve the outcomes. For Group A patients, treatment begins with a bronchodilator. This may be a short-acting agent such as salbutamol or ipratropium, or a long-acting bronchodilator if symptoms persist. The goal is to relieve the symptoms and improve quality of life. Therapy should continue only if the patient experiences a noticeable benefit. For Group B patients, GOLD 2026 recommends dual bronchodilator therapy using a long-acting beta agonist or LABA combined with a long-acting muscarinic antagonist or LAMA. This combination improves lung function, decreases breathlessness, and reduces exacerbations more effectively than monotherapy. Single drug therapy may still be considered if cost or tolerance limits treatment options. Patients in Group E are at the increased risk of exacerbations, and the preferred initial treatment is a combination of LABA and LAMA. And if blood eosinophil counts are 300 cells per microliter or higher, triple therapy with LABA or LAMA and inhaled corticosteroids may be considered. Importantly, the GOLD guidelines discourage using LABA plus inhaled corticosteroids alone because this combination increases pneumonia risk and provides less benefit compared with the triple therapy. Blood eosinophil count has become an important biomarker in COPD management. Patients with eosinophil counts below 100 cells per microliter generally derive little benefit from inhaled corticosteroids. Counts between 100 and 300 suggest moderate benefit. Patients with eosinophils above 300 are more likely to benefit from inhaled corticosteroids and triple therapy. This personalized approach helps optimize treatment while minimizing unnecessary side effects. When symptoms persist despite treatment, medication escalation should not be automatic. Healthcare providers should first assess inhaler technique, adherence to the therapy, comorbidities, and opportunities for pulmonary rehabilitation. Many patients improve simply by correcting inhaler use or addressing other contributory conditions. Triple therapy combines a LABA, a LAMA, and an inhaled corticosteroid. It is recommended for patients with frequent exacerbations and elevated eosinophil counts. Clinical trials such as IMPACT and ETHOS have demonstrated that triple therapy reduces exacerbations, improves lungs function, and enhances the quality of life. However, inhaled corticosteroids should be used selectively because they may increase the risk of pneumonia. Medication alone is not enough. Every patient with COPD should receive comprehensive non pharmacological care. Smoking cessation remains the most effective intervention to slow the disease progression. Vaccinations against influenza, pneumococcus, COVID 19, and RSV help prevent respiratory infections. Pulmonary rehabilitation, regular exercise, nutritional support, and patient education all contribute to better outcomes and improve the quality of life. A major advance in COPD management is the emergence of biological therapies. Patients with severe eosinophilic COPD who remain uncontrolled despite triple therapy may benefit from biologics such as tepulimab and mepolizumab. These medications target type 2 inflammation and represent a move toward precision medicine in COPD treatment. Acute exacerbations require prompt treatment. Short-acting bronchodilators are administered to relieve airflow obstruction. Oxygen therapy should target oxygen saturation between 88 and 92%. Systemic steroids, usually prednisone 40 milligrams daily for 5 days, help shorten the recovery time. Antibiotics are indicated when bacterial infection is suspected, and patients with respiratory acidosis or severe respiratory distress may require non invasive ventilation, such as BiPAP. The major messages from Gold 2026 include the ABE classification remains central to the patient assessment. Dual bronchodilator therapy with LABA and LAMA is the cornerstone of the treatment. Blood eosinophils help determine who benefits from inhaled corticosteroids. LABA plus inhaled corticosteroids alone should generally be avoided. Pulmonary rehabilitation and inhaler technique are emphasized, and biological therapies are opening a new era of personalized medicine for the selected patients. In summary, COPD is a progressive disease that requires early diagnosis and individualized treatment. The GOLD 2026 guideline emphasizes dual bronchodilation, selective use of inhaled steroids, pulmonary rehabilitation, and personalized therapy based on eosinophil count. If you found this video helpful, please like, share, and subscribe for more evidence-based medical content. Thank you for watching, and I will see you in the next video. Allah Hafiz.